Pregnancy and birth are very emotional experiences. What I would like you to take away from today's discussion is the importance of that emotional connection during pregnancy among all of those people around the pregnant woman and the baby. And when I say emotional connection, what I mean is that the parents, they know how they feel, their own feelings, but they also understand and feel what the baby's feeling. So that both are true. And also that the caregivers who are taking care of the mother and the baby and the father, that the caregivers are aware of their feelings.
Welcome to In Contact with the ACO. I'm Dr. Chris Burritt. This presentation features the care of a patient by one of the ACO doctors who practices a different kind of psychiatry. There is a new case presented live each month at the ACO campus near Princeton, New Jersey. Each podcast episode is from the recording of a presentation. These are real patients, but their privacy is protected. If you're interested in attending, you can meet the doctors and join in on the discussion afterwards. You can connect with us and learn more at adifferentkindofpsychiatry.com or orgonomy.org. In this episode, you'll hear Dr. Susan Marcel discuss two patient cases. The first is about a patient she helped as a medical student, which highlights the importance of emotional connection and expression during childbirth. The second touches on the importance of the doctor-patient relationship, but also how Dr. Marcel helped her patient address her fears and clear her confusion. We're once again happy to bring you more, so stay tuned after the presentation to listen in on the audience discussion.
So the first patient I want to tell you about is a patient named Jean, who was the very first patient I ever worked with in my first medical school rotation in an OBGYN hospital up in Erie, Pennsylvania. I was a third-year medical student, and I was assigned to her she was giving birth to her first child, and she was very scared, and she just wanted to talk. So I was assigned to go in and take her medical history and ask a whole checklist of questions and then do a physical exam, and that would probably take a little bit under an hour. And I had been trained to ask the checklist of questions like past medical history, her surgeries, her medications, any allergies, does she smoke, does she drink, did she have any problems during the pregnancy? So I started writing down the information pretty mechanically, and I was like a well-trained robot, a little third-year student with a little white jacket. And I was not connected at all emotionally with Jean. And as I went through the interview, though, and every time I looked up at her, something started to happen between us. I could feel something changing. And I would ask her another question, and I couldn't help but notice this kind of sad, frightened look came into her eyes or on her face. And the more I saw it, the more I could feel it and then perceive it. And then my attention began to focus on her emotional state rather than the checklist that I was assigned to find out. So we spent the next 2.5 hours talking. In between her contractions, she was in early labor, and she slowly started to tell me a very moving story about her first pregnancy, which she lost several years ago. And she had never shared that story really with anybody in depth, and she was still very deeply affected by it. And I'm sitting there in the chair next to her bed and thinking, why is she telling me all this? I was a total stranger, and I wondered, what is this? And she was concerned about having this baby and the health of this child, and she was anxious about not knowing what to do during labor, delivery, and then when she brought the baby home. And I thought, where was the father? Why was she alone without any friends or family in this delivery suite? So I quietly asked myself these questions, and I saw her eyes tear up, and her shoulders were kind of tight. And then she started, as she told me this story, she started relaxing her shoulders down, and her face became sadder looking, and her mouth was kind of downturned, and she turned her body towards me, and she started weeping and sobbing very quietly. And her breath got deeper, and she sighed in great grief over the loss of her first pregnancy. And at the end of our time together, she just tenderly thanked me for listening. and said that she felt better for just sharing the story of her fear and her grief, and it had burdened her so for the past few years. So I left that hospital room. I was very moved. I was teary, crying, and I couldn't believe what had just happened. And as I walked out, the staff scolded me for taking so long, and they were busy setting up an IV pole and gowning and gloving and all the, the instruments one might need for, delivery. And I'm thinking, how could the staff not see this woman's sadness, or mine? That something happened. And why was the IV more important than this woman's grief and fear? And why didn't anybody else try to listen to her, but like the lowly third-year medical student who didn't know this woman at all? So, left a very deep impression on me. Jean went on to successfully deliver her baby, and she went home 2 days later, very tired, but feeling well. We had both connected, and we were both changed in that process. That patient left such a deep impression on me. But I was left mystified by the absence of that emotional connection between Jean and the staff. And especially if they may have known her obstetrical history, that she had lost the first pregnancy. And over the years of my training, I often remember my first OB patient, Jean, and I wondered how we as the medical profession, how can we improve the care of pregnant women and newborns? And what is it that moms and dads-to-be need from the caregivers and from their families? And then what gets in the way of connecting with them emotionally? And what effect does this have on the baby? And can we listen differently to pregnant women? And I think these are questions that have to constantly be asked. So the way Jean and her baby were treated just seemed really off to me, and it lacked compassion. It was cold. Jean said to me, "I'm scared to give birth." She was terrified. And she was aware of her own feelings, and she was moved to tell me about her sadness. And my response was to just sit there and listen and say, it's okay to be afraid. Together we'll get through this. You don't have to do this by yourself. So the busy excitation of the monitors and the IV and the staff and the hustle bustle, it interfered with the staff being able to perceive Jean, but also it made Jean hide. She couldn't let herself be open and say what she was thinking because she perceived all the flurry and the noise around her. So when I sat down by the bedside, something changed. There was this spontaneous thing that happened, and it just allowed her to relax and share her story and then deliver her baby. So the second patient I'd like to tell you about is a story of a patient that I'm currently taking care of. Her name's Anne. And 12 years ago, Anne consulted with me for a second opinion regarding a very severe depression that she had. And she and her husband wanted very much to have children. And she had been diagnosed with something called bipolar affective disorder. And it manifested mainly by very severe depression. And once in a while, she'd get very anxious and manicky. She was taking 3 medications to control her mood and her depression. And her psychiatrist told her she could never have children because of the bipolar diagnosis and the medicine she was on. Because the medicine could cause birth defects in the baby. So she was devastated by this news, and his comments only served to deepen her depression. And she'd always imagined herself as a mother, and this was a great loss to her. And her psychiatrist insensitively delivered recommendations, sent her into a really dark period of her life, probably the darkest of her life. His stated opinion hurt her very deeply, the way it was delivered and what he said. And she withdrew in fear, and she never trusted anything else that he said after that. Technically, the psychiatrist was giving her accurate and good information, and he was treating her based on the diagnostic and statistical manual that psychiatrists use to kind of label illnesses and guidelines, and he was giving her medication appropriate for her symptoms, but there was no perception on his part as to the effect of what he said to her and how it made her feel. So she asked me very poignantly, would you help me? So Ann and I talked a lot about her fears and my concerns about her diagnosis, and if she became pregnant, being so depressed, and if she was on very powerful medication, what would that look like? What risk to her and to her baby? And we were both very scared of the prospect. And I made no promises to her at all. I was very clear and honest with her about, what my reservations were. And if I lowered her medicine, say, or got her on different medication, I told her I'd be willing to try, but that I had great reservations. And we worked together for the next 3 to 4 years in therapy. She came about every 2 to 3 weeks. And she began to tell me the story of her childhood and her about her parents and her work as a school teacher, which she loved very much. And she was very maternal towards the kids in her care at the school she worked in. She started telling me of her deep love for her husband and how much they wanted to start a family. And we also began to realize how she tended to avoid her emotions. And she did this by trying to control everything. And that was her main way of avoiding feelings. And the other thing we learned was that when she cried, it gave her a sense of relief. So I prescribed various medications for her that she could tolerate, but that would have a minimal effect on the baby. And it was a very challenging experience for me as a prescribing physician, but also as a psychotherapist, because I was afraid of relapse. And there was a great deal of fear and frustration and sadness in Ann. And her moods would go very low, and then she'd pop back up, and sometimes she would call me anxiously in between sessions, and it was almost like she just wanted to make sure I was there. Are you there? Are you there? And through all this, she developed trust in our relationship. She knew that I really took her seriously, and I got it. I understood what she was going through. She began to have longer episodes of stability and a sense of wellness, and her depressive periods got shorter and shorter in duration. So by the 4th year of our working together, we agreed that maybe she could try to become pregnant. And she conceived and delivered a baby girl. And her depression cleared considerably after she delivered. And she could tolerate much more of those deeper emotions. She didn't just have to suppress them down or medicate them away. She could actually feel them and express them. She was more able to connect with me emotionally, with her husband, and more importantly, with her beautiful daughter. About 1.5 years after her daughter was born, she said to me in a session, Dr. Marcel, motherhood saved my life. Ann needed somebody to trust, somebody to help her with the fear and the mistrust. And we connected on a very deep emotional level, and it helped her face the depression and her fear and her anger and sadness. She's currently on 3 medications, very low dose. And I'm happy to say Ann's daughter is 7 years old and is the most beautiful little girl you could imagine. And recently Ann's husband came in for treatment with me because he had some issues and symptoms. And that's helped the whole family function differently, which is ultimately much better for their daughter. So fostering trust is right from the start. That's my prime directive. That warm, trusting doctor-patient relationship that we developed allowed Ann to enter therapy and to begin facing what she was trying to control and run from. And as she progressed, she actually became a much better mother. And finally, because of this, her husband came, and he's a better father. And slowly, the whole family changed because of her courage and our work together. So thank you.
What you said about when you was patient and like the mother, like I think her name was Ann or something like that. Mm-hmm. I think with that, like I can kind of relate to that because it's very true. Like sometimes it's periods in my life where I get stuck and I just don't know what to do. Like I'm a first time mom. I never raised a child. It's my first time raising a child. So it's just like sometimes I don't know what I'm doing, and I just get very scared.
Sure.
So, yeah.
It's hard work, yeah. There's a few things that stand out to me about Dr. Marcel's presentation. There's a lot. One thing that stands out is what Dr. Marcel said about, as she's talking with Jean, about really looking at her rather than just taking in information. If she wasn't able to make eye contact to look at her face, she wouldn't have a sense of how Jean was feeling. And then when you see what you see on her face, you have to connect with it and respond. And I think that's what Dr. Marcel did really well. She connected with her emotionally and allowed her to feel comfortable enough to express her fear. And it sounded like Jean very much needed to express that fear so she could go on to deliver her baby. Somehow the rest of the staff, whether they're just by going through the motions, they missed the opportunity to really connect with her. And it really begs the question of what is the medical personnel's role in treating a pregnant mother? Is it to simply get the baby out of the womb and bring it into the world, or is it to be there for the mother? Is it there to foster the connection between baby and mom? So there's a lot there, but some can come in to say I'm depressed, but or I'm anxious, but really what they need is to feel someone they can trust to express themselves. And it sounded like for Jean that was part of what she needed.
I think my view of myself as a third-year medical student was I was the lowest on the rung, the ladder, and I didn't, as my very first patient, I don't know that I understood my role, but now I teach medical students at Jefferson, and I see the vital role that they play. They often have the time to sit and listen and make eye contact and perceive and connect in a way that, a busy intern who's been on call the previous night before can't do that because they're too tired or they've got other duties. So I appreciated how my role, at the time I didn't appreciate it, but now I do. I have the 2.5 hours to sit and listen to Jean. And a doula has time to just sit and be, with a mom who's about to deliver. Yeah.
And with a doula and other staff, there's training of our role, is to be there for mother to understand what she wants, and sometimes that gets lost for the medical process of what fears do you have, what concerns do you have, who are you as a person, what do you need. I think oftentimes for an OBGYN visit, that those questions don't come up. It's, how much do you weigh, how are you feeling, or do you have any pain?
That's it. That's it. That's one question.
Yeah. Other impressions people have about pregnancy, birth, generally?
The question about the trust thing, is there a trust that is hard to explain between the fetus and the mother before the baby's born? And what does that look like?
That's a great question.
What was the question?
Whether there's a trust connection between the baby who's still inside the mother and the mother.
Yeah, it is. I know it is. Yes.
Speaking it.
Yeah, it is.
So that relationship starts very early, even before delivering the baby.
There's actually a study I read earlier that there's a woman named Catherine, I'm blanking on her name, Catherine Hanks. She is a Columbia University Medical Center researcher, and she took 50 women and has been following the women through their pregnancy and their babies at 4 months, and now they're about to 2 years, and to look at their stress level. So stressed out, depressed, anxious mom, their children are less resilient and show more reactivity, more colicky at 4 months and then at 2 years. And so there's something about that early bond, if there's a warm relationship, that's happening between the baby and the mom. But if the mom's very depressed and anxious, it looks like it definitely affects the child as, in the womb, but we can measure it at 4 months and 2 years. So,
Pregnancy and birth have a profound effect on women and families, on fathers. I have a patient who's turning 62. She lost a pregnancy like over 25 years ago, and every spring it still affects her. You know, there's a solid week where she's profoundly affected 25 years later, and I think that can get lost in just our thinking about pregnancy. It very much affects families and parents. So I'm just thinking of, Jean again. She had a miscarriage, and how did that play a role?
I know I had encouraged her to seek help when she left the hospital, maybe find somebody to talk to. But at the time, I didn't know the services in the community where I was working. But I encouraged her, find someone to talk to. So I always wondered what happened to her.
Yeah.
It was so many years ago.
I think you say that, and it makes me think. I'm sure she remembers you. That. And
I want to hope so.
I believe so. I think you talked the first story 2.5 hours of a connection, and in 4 years. But I think it made as much of an impact on both.
Yes.
That somebody stopped to care and to talk.
Yeah.
So many times, hustle and bustle of of a checklist. Like I got to get through my checklist.
Yes.
But
That's how I was trained. Go,
Yeah.
go. I had to go on. I had other duties, and I'm glad I didn't leave. I'm glad I stayed and just hung in there and left a profound impression on me. And taking care of pregnant women is something I love to do, and I think it has. I can thank Jean for that. It's one of my first early medical school impressions.
Thinking about this medical, profession, treating mothers, treating all patients very mechanically. Part of that is also they're using their authority to convince the mothers and other patients that they are machines, and distorting their Well, this is an example from a long time ago, but I think there are things now that they used to prescribe very, very detailed spoon and dropper fed diets to babies on a strict timetable and so forth. And
that was in the 50s and the 60s.
Yeah.
I think about your patient, Anne, talking about her fears of not being able to get pregnant. I don't know if this is what she said about motherhood saving her life, but it is, she wanted to trust herself and to face her fears of pregnancy and delivery, and that's my sense of what she means when she says that.
She's one of the most courageous patients I've ever worked with. She's got that quiet courage of, okay, here's the problem, I have to do something. But she never knows what to do, so she looks to me to kind of guide her through that, and that's been my role, is to just see her, help her organize her thoughts. And she really wanted to have a child, and she's worked on many other things too over the years in our work together. I helped her trust herself. I think that what she wanted was essential and vital to her own liveliness and her own life. Motherhood saved her life. She was very depressed. And I don't know where she'd be if she didn't have her daughter. I shudder to think about that.
One thing that stands out is, you expressed your concerns, your fears, and you also had the opportunity to do that because my guess is the psychiatrist who saw her before wasn't in therapy with her.
No, it was just medication management. And she didn't really have anybody to talk to about what she was experiencing emotionally.
Which can be the typical routine these days. You see a psychiatrist, and sometimes you may also see a therapist, but they're two different people. And so if there's real concerns about the medication, like in this case, who do you really have to trust to discuss the pros and cons of different routes you could go, or just how overwhelming it can be? So it sounded like it was vital that you were there for both
of those
prescribing
roles.
medication and being there as her therapist.
Yeah, I always look forward to her coming in for sessions. just because I knew where it was going and where it could go, but I was scared also. So I had many different emotional responses to her, but I think that helped because what I was feeling often was what she was feeling. You know, her fear, I would be afraid, but to use that as kind of a compass to help guide the treatment, and it ultimately, you know, ended up in a very positive outcome. And I've met her daughter. Her daughter is just this beautiful Cinderella princess kind of 7-year-old that is just delightful. And I think, you know, she wouldn't be here if this mother didn't have that courage to try, and I helped her with that. So, yeah.
With the aspect of time management being a medical professional, in the sense of you need to be a psychiatrist and do with the medication management, but also be a psychotherapist, that takes more time with a patient. You have less meetings with them. Going back to your clinical rotation with Jean, you know, you spent 2 hours with a patient, and that was borderline unacceptable because that's wasting time, even though it was extremely effective and valuable. So where does the balance of, you know, treat as many people as possible because you have a medical duty to serve as many people, but also have the quality of care that comes with establishing the trust in psychotherapy?
Well said.
Yeah.
I don't have the answer. But we need more doctors and therapists and doulas and nurses and midwives. Some of the midwives and doctors that I talk with, the OBGYNs refer to the midwives as Jedis because midwives did the bulk of the work, and because there weren't enough OBGYNs. The hospital I worked at, there was one OBGYN for the whole hospital. This gentleman was on call all the time. His poor family. I don't know how he did it, but he loved it. He was good at it, but he was busy. So that time management question. But I think it would have been better if it had just been explained, like, okay, here's the hierarchy. I had to figure it out as I went, but I had the 2 hours, but an OBGYN may not have the 2 hours. And should we expect that of doctors? And I don't think time-wise that would probably work in our system, but I think even in 2 minutes with a patient, you can establish eye contact and just kind of connect and open someone up who might not be feeling so good at the moment. You can recognize that. But that takes the OBGYN being able to know how he or she is feeling. That may or may not be happening. I don't know.
I think also the short answer is you have to be aware that that's even happening as the doctor or the medical professional.
Sure.
So in the short term, you can do whatever it is to be available or to manage your time in a way that's helpful for the patient. To ask yourself, what is my role? Meaning, am I here to help heal the patient? Am I here to be supportive? Or is it just to, like I said earlier, is it just to have the baby come out with 10 fingers and 10 toes? Or is it more than that? But I think the bigger answer is reevaluating the system that we have. And I think we have seen that over time. You know, Dr. Marcel and I were talking about just the differences in her delivering her children. We had a child December 2017, and we're expecting another one. And there are a lot of changes that have happened. I think in some ways there is a lot of positive movement in maternal care and pregnancy and delivery. I think it can still get better. I think it's also different people are on different pages. So the hospital may have rules, individual medical staff may have their own feelings. You may have a doula or not. You may work with midwives. So I think we're in the middle of kind of that changing. So I'm hoping it will continue to go in a good direction. For instance, like where we're going to be delivering our daughter in the summer, they have this golden hour that after the baby is delivered, there's no testing. You know, typically it was you take the baby off and you do all this stuff, and then when they're done, okay, maybe mom can have the baby back, right? And now it's this hour of no one's going to disturb mom and baby. Let the baby just sit on mom's chest and breastfeed and connect, which I think is amazing. And that's actually what we had for our last daughter. But you know, it's funny because we were in the midst of it all, and we were looking at pictures the other day. You know, like iPhones now, they have that 3-second video that's like a moving picture. We were watching it, and it was a picture of just our daughter on my wife's chest, and you hear in the background during the video, like, oh, when was her due date? And it was the nurse, like, I said, like, buzzing around like a bee. Like, who's asked, like, what does that matter? You know, the baby was just delivered. Who cares about the expected due date?
Gotta fill a form out.
Excuse me. So it's almost, you know, in the past authoritarian time, it was, this is the way things go. All right, you're going to follow us, and you're almost feared into doing whatever the doctor says or whatever the institution says. And now it's almost like people are clueless. Like, why would a nurse ask that question? Like, it's nothing to do with what's going on right now. And so in some ways, that's now the problem we face, is just people are just out of it and don't recognize that the importance of mother and baby being together. And so I'm hopeful things will change, but I think that's what we have to face. Well, one of the reasons I'm here is because not only am I passionate about this as a clinician, as a psychiatrist, but as a first-time father, as I'm going to have another child, and there's still a lot that I'm learning about this whole process, and it can be scary. You know, as a physician father, then it's extra scary because I have in the back of my mind.
You know too much.
Yeah. And you know, as a father, my wife is going to most of her appointments with, whether it's the midwife or an OB, and I went to a lot of her appointments, but I don't really have the same relationship that she has, and so I get afraid, you know, can I trust this person? So really what I have to do is trust my wife that she can trust the clinician, and you know, kind of face my own fears and not let my own anxiety become infectious to my wife, because she's calm. Well, I'm anxious, but I'll deal with that separately without, you know, giving it to her. But it can be a very scary process, even with everything we know and modern medical abilities.
Well, I have one other wonder. I mean, just answering that question, how can we better take care of fathers-to-be? You know?
That's a good question.
Because the focus is all on the mom and the baby. But the dads, you know, where are they in the process, and what can we do better for them? I don't know that's... I think about it. I don't know if it's formally thought about it, but there are parenting classes, you know, after the baby's born, and there's, you know, the fathers are included in the, you know, prenatal visits and classes. But what do dads really need? I don't know.
Well, when I was growing up, fathers, when the delivery process came up, they always sent them to go boil water. I never understood why the father had to go boil water or whatever. And then I learned that it was just to get him out of the way and make him feel like he was doing something, but being open to maybe a more inclusive aspect of the father being, you know, right there, and maybe being taught or advised about what his role can be. I mean, I remember the first time when our firstborn son was born, and I held him in my arms for the first time, and these big eyes are looking up at me. It was 26 years later. You know, that vision is still there in my mind about that, you know, initial experience of what that all felt like. It was really great to be in the room and be a part of that whole process.
Mm-hmm.
I think that maybe part of the answer is just asking fathers what they need and really finding out. You know, the thing that pops in my head is that these days I think there is more involvement with fathers with children. In some ways it almost is, the role isn't clear though. There's more involvement, but what is their actual role? And in some ways it seems like being unclear. Father and mother are sharing what traditionally was mother's role, you know, in feeding the baby, and that may be the right thing for one family, where it may not be right for another family. And I think that maybe the question just needs to be asked more. Another thing that stands out about pregnancy and childhood delivery, I think because it can be such an intense experience, it really puts us up against our own way of dealing with feelings. So in some ways, that can be a gratifying experience to really overcome whatever, you know, if it's a fear about pregnancy and delivery, about being a parent, but you really have to adapt to parenthood. I mean, that's in TV and movies all the time, but you really we all have our ways of dealing with our feelings and handling them, and sometimes they work out better than others. Just looking, again, my own experiences, I like to plan and have time management. I like to exercise. You can't do all that when you just had a newborn baby and your wife needs you and you have to work and pay the bills. So, for instance, for me, I have a certain way of dealing with my feelings, and I couldn't do that anymore, so I had to adapt and figure out a different way. And I think we all face that, generally with big things that happen, but I think especially for pregnancy and delivery. We have to face our feelings and manage them as best we can. But maybe anyone else had that experience?
Well, it doesn't only affect delivery and newborns. It's as they grow, you're adapting and changing
Exactly.
all the time.
Sure. Yep. And teenagers.
Can you say more?
No.
You sound like you speak from experience. A little bit.
You do learn a lot about yourself. When I had Talia, I moved away from my family to another state, and I was really by myself. And
Oh, wow.
got pregnant right away after we got married, and I just learned a lot about myself.
I'm just wondering if, looking back, even around the world or back in history, is there some kind of is there a culture in your minds that had the most positive attitude toward motherhood and childbirth? I mean, is there something that was...
From what I've read, matriarchal cultures have a healthier outlook on pregnancy, birth, and emotions. But I can't say I'm the expert to say how, but that's my impression. Well, there are some matriarchal cultures now. There's some African tribes that are matriarchal. There's some in New Zealand, the Trobriand Islands. There are some matriarchal cultures that still function in that the mother is the kind of top, and it all surrounds the matriarch. So, but I can't say much more than that. But that's an impression that I have. I think what Dr. Barrett was referring to is the more authoritarian, maybe patriarchal way of, you must do this, you must feed your baby a certain time, in a certain amount of ounces. I mean, it's very rigid and authoritarian. And I think that the whole point of I think these two cases, these two women that I worked with, the whole idea of spontaneity of emotional expression was just not on anybody else's radar, and yet that is what they vitally needed, and to be able to. I think with Jean, the first woman, I think she had a better labor and delivery because of the 2 hours. I think it relaxed her. It was still difficult for her for some reasons, but because when she was in labor and delivery, I didn't really say this, but when she was going through the birth process, when the staff was being a little more intrusive, she would tighten up and tense, and I could see it. And so, but I think me being there, being present, helped her relax in some way and allowed her to deliver the baby successfully. So, I don't know.
What you said about learning about yourself, it's lifelong. My grandchildren are teaching me so much about themselves.
There you go. Yeah.
We get stirred up in many ways with babies, and not all of us want to learn more about ourselves. Not all of us want to see parts of ourselves, and you wonder how that affects people's interactions with children and with pregnant mothers. There's to really connect with yourself can be very, very challenging and difficult, and in some ways, if forced to, because of interactions with a very lively, healthy young baby. That stirs people up. So that's the other thing we face. Very, very emotional.
Well, I'd like to thank all of you for coming and for sharing your ideas, your thoughts, and look forward to maybe seeing you again at our future case presentations. Thank you. Thank you all.
Thank you.
What reaction do you have to these patients and their treatment? Do you have any feelings about pregnancy, childbirth, or raising kids? I'm happy to say that our second daughter was born last July and is happy and healthy. Just when I thought I was getting my bearings. Truthfully, there's probably nothing more exciting than raising our children, but I've also never felt more vulnerable in my life. What has your experience been? Are you pregnant or raising children? Are you a father? We are interested in your questions and comments. You can connect with us and learn more at adifferentkindofpsychiatry.com or orgonomy.org. If you like our work, be sure to leave a favorable rating. Find more episodes at Apple Podcasts or wherever you get podcasts. Be sure to check out our next episode, which features Dr. Dale Rosen's remarkable treatment of a young girl with terrifying intrusive thoughts.
I received a desperate call from a mother who said, "My 9-year-old daughter is having a nervous breakdown. She's having crazy thoughts at night that we're going to kill her and that terrorists are going to come into her bedroom through the window. She even has crazy thoughts that her father may harm her. I'm afraid she's going insane."
I'm Dr. Chris Burrett. Thank you for listening to In Contact with the ACO. Since 1968, the psychiatrists affiliated with the American College of Ergonomy have been helping patients discover greater satisfaction, health, and overall well-being in their lives. Whether patients suffer with mental illness, struggle with addiction, or feel unsatisfied with their work lives or relationships, medical orgone therapy as practiced by the physicians at the ACO offers a way forward, often without the use of medication.